Okay. All right. Well, thank you guys all for being here. This is a really exciting night for us. So welcome on behalf of ISG. We have some new fellows and a resident with us tonight, so we'll be presenting some cases. We're kind of doing something maybe a little bit different than what we normally do in the past. This kind of came out of a conversation between Jens and Rick and some of the Magrill X-Fix techniques. And in a sense, Barrett and I kind of chatted a little bit and shed some light on how much we don't really talk about this stuff, kind of past techniques or past surgeries that maybe aren't utilized that much anymore. But in a sense, losing touch with some of those basic principles and techniques of early spinal fixation. I think a lot of that really is just because it becomes so hyper-focused on innovation and strengthening our spinal fusions with cutting-edge techniques, and then some of the nuances that we focus on that are associated with those, such as adjacent segment disease and sagittal alignment. And as the advent of patient-specific rods and all these new type of technology platforms come in, we really kind of start to lose sight of where we came from. In a sense, it kind of harkens on that old proverb: you can't really know where you're going until you know where you've been. So I think that this topic today is really kind of conducive to that, and really kind of hopefully emphasizes that to you guys. If you think back to where we've been, you think back all the way to Lister and the advent of general anesthesia and the advances in early 1900s with Hibbs, with uninstrumented fusions treating Pott's disease, all the way to Paul Harrington and the Harrington rod in the 1940s and 60s that we saw that kind of advent of that. And then, it's almost hard to forget the Smith-Robinson approach and the anterior cervical fusion in the 1950s. And then, fairly quickly, we saw kind of the Roy Camille, the Magrills, the Harms, and really kind of what is today the modern day pedicle fixation. So, it's, in a sense, we look at these as very historic, but if you look at them as we kind of hope to look at tonight, you'll see that a lot of these, like the Harrington rod, has 20-year follow-up with excellent postoperative satisfaction scores. So these things were really cutting edge at the time, and a lot of the concepts that they touch on, I think, are things that we've really built our current techniques off of, and I think are important to remember. So tonight we're really hoping to do this via kind of a case-based discussion with our two newest fellows. So Jason Yee and also Brandon Petrone. We also have our kind of all-star fourth-year resident, Emily Zielinski, who's going to be applying for spine fellowships coming up. So she'll be the hot ticket on the market pretty soon with the match coming up. So these three folks will be presenting cases, and we'll have them kind of kick it off. And again, really feel free to chime in, because a lot of this stuff I've never done, never seen. And you just kind of have that weird x-ray that shows up in your clinic going, what the heck is that? And I got to call Rick. I'm like, Rick, what am I looking at? Because you're the only old guy that knows what this is. So please chime in so that if you have some kind of interesting stories or interesting past on the topic. Brandon, do you want to kick us off? Yeah, you're good.
So good evening. I'm Brandon Petrone. I'm one of the spine fellows here at Indiana Spine Group. I don't have any disclosures for this talk because I'm just a fellow. So here's an interesting timeline that kind of describes some of the advancements in spinal instrumentation that Dr. McCarthy was leading us into. We see that in the kind of like the late 1950s, early 1960s is when the Harrington rods came out. These were kind of the cutting edge spinal instrumentation at the time, and they were mainly used for deformity. But because of this instrumentation system, they slowly began being used for degenerative syndromes as well as trauma. But each kind of developed its own new set of problems with it. And then in the early 1970s, the Lukey instrumentation system came out, and this was cutting edge at the time because this is one of the first kind of segmental instrumentation used, and it was kind of used at that time. And then there's been many advances, especially with the Steffi pedicle screw and plate system, the Roy Camille pedicle screw system. And then it wasn't until the kind of late 80s, early 90s when there was a lot of class action lawsuits against pedicle screws, where the majority of them were kind of pulled off the market. And then in the late 90s is when the FDA approved pedicle screws. And this has been kind of the mainstay of the instrumentation that we use today. Here's just some interesting x-rays and photos of some of the instrumentation development over the years. We can see in the top left here, we have the Lukey instrumentation system with the sublaminar wires and rods. This bottom center photo demonstrates the Harrington rod construct. That top left photo is a demonstration of the Steffi pedicle screw and plate systems, which were kind of some of the first, those as well as like Roy Camille were developing some of the first pedicle screw systems at the time. And these kind of were fastened down to the plate with bolts. And on the bottom left here, we see some of our more current instrumentation with our pedicle screws and rods. And then, you know, today we have a lot of development in interbody techniques as well as interbody instrumentation, and even in the interlaminar space as well. So significant advances over the years. But I'll present the first case here. Interesting case is a 55-year-old male. He presented to our clinic with 2 to 3 years of worsening low back pain and pain radiating into his left gluteal region. He's also noticed that he's been having increased pain with increased ambulation, which has decreased his ability to kind of walk over the years because of this increased back pain. He denies any other radiation into his lower extremities. His past surgical history is significant for adolescent idiopathic scoliosis, which was treated with a posterior spinal fusion in 1979 in Singapore. The rest of his history is unremarkable. His exam is just significant for decreased flexion due to pain in his lumbar spine, but otherwise his strength and sensations reflexes is intact. So here are 2 X-rays standing scoli films, AP and lateral, demonstrating instrumentation with the Lukey instrumentation with the sublaminar wires and rods from T4 down to L2. We see some retrolesthesis here at the L2-3 level, just at the end of the fusion construct. But as we look closer on the AP and lateral lumbar films, we see again that retrolesthesis of L2 on L3, but also some significant disc space degeneration as well as lateral listhesis of that L3-4 level, which is distal to the instrumentation. Here's sagittal and axial T2 weighted imaging demonstrating severe disc space degeneration and type 2 modic end plate changes with some lateral recess and subarticular stenosis at that L3-4 level. So our diagnosis here is we have a 55-year-old male with L3-4 degenerative spondylosis and lateral listhesis with radiculopathy below a prior fusion. So based on his imaging and presentation, what treatment options would you recommend and what is your thought process behind
it? This is Izzy Lieberman. Let me chime in on one thing. Brandon, if you can go back on a couple of those x-rays.
Yes, sir.
The initial AP and lateral standing x-ray that you had. Just wanted to point out something there. So look at the configuration of that idiopathic curve. I suspect that if we saw that curve today, that individual would have not gotten surgery. That was not a very extensive curve, more of a long sweeping type curve. So I just wanted to point that out. And then also the technique, which was really good at the time, but the surgeon who took care of that had to pay such meticulous attention to the fusion, because if he didn't, that hardware would have probably broken, those rods, wires would have pulled out. So there's a lot of history in that one x-ray there.
Well, I think that's I was going to say the same thing. It's a great point, but going on to what to do now, how many people would treat the current problem, which seems to be the immediate adjacent segment, versus staging this, because you know if you do 3-4, you're going to be back at some time to go below. What are the different philosophies? And I know we, at our conferences at TBI, we go back and forth to the specific at the time, or I want this to be my last operation, doctor. What do you tell the patient?
First, it's never going to be his last operation.
Well, if you go all the way to the pelvis and do sacroiliac fusions, it might be.
Well, you might get PJK at the upper end too.
Right. We're talking about the lower end now. You know, obviously, I mean, again, you've got obvious pathology. You know, as we all know, back pain is very multifactorial. So even if you treat the degenerative and lateral aesthetic 4-5 with modern 3-4 and do modern techniques where you're going to do an inner body, you're going to put some pedicle screws in this and that, it's unlikely you're going to get 100% pain relief, and it's unlikely that with enough time 4-5 and 5-1 are going to stay uninvolved.
This is an example of what I would consider a great case for symptom-specific surgery. If you can identify that 3-4 level is truly his symptomatic level on the basis of his history and exams, he's getting a 1-level fusion to address that. And
what if it's just back pain alone and it's impossible to be 100% sure that's where it's coming from? Now, if they got a L3 or L4 radic.
Well, watch, let Brandon answer the question. Brandon, what did you do to identify that was a level that you thought his pain was coming from?
I think just based off the imaging and the, we definitely didn't do any sort of like selective nerve root injections, or none that I saw in the note, but just based off his imaging and his presentation, and looking at that lateral aesthesis, he does have that kind of that radicular symptom going on the left side, which is sort of at the concavity of his curve in that lateral aesthesis. I think it was just the thought process behind it was really, if you look at the films too, his L4-5 and 5-1, they look relatively benign. And
did you have an MRI scan to show that?
Yes.
I mean, would anybody consider, if you said radicular symptoms, of just trying an L3 nerve block to see if indeed that was what the radicular symptoms, that if they could be temporarily relieved with a local anesthetic effect? I don't know.
Absolutely. And I wouldn't operate on him at all unless I knew where his pain was coming from. There is a myriad of possible sources of this guy's pain.
Yeah, actually, although the axial of I assume it's 2-3, doesn't look perfectly normal. On the sagittal, the signal looks pretty good there, as well as at 5-1. 3-4 looks terrible. 4-5 is degenerative and narrowed. So I don't think we know where the pain's coming from, at least at this point.
That's right.
Particularly if the big component is back pain.
Come on, he has substantial modic, is my case. He has substantial modic end and play changes directly beneath a very long construct. He's a thin, hardworking guy, works at Amazon. He has very well preserved discs. We can all be nihilists forever if we never know 100% where things are coming from. He's got radicular pain. It sounds a heck of a lot like L3. I can't tell you. Brandon did the chart review, and I'm going from memory. I thought he had a nerve blocker, an epidural at some point along the way as part of conservative therapy. But I mean, this disc is a totally trashed, directly adjacent to a long construct that's been there for 40 years, and that's great work on the Lukey instrumentation to not provide more degenerative changes faster at the level below. But I think this is reasonably straightforward.
Do you worry about, if you don't include 4-5, you worry about 4-5 at all?
Yeah, I worry about all my patients that just like vascular surgery is a staged amputation, we're all staged, occiput to pelvis. It's just how far you make it. Is that a possibility? Yeah, I mean, yeah, it's a possibility. He's 55.
So we're using this term back pain as ubiquitous. There's tons of reasons, obviously, for the back pain. And this is an arthritic, mechanical, degenerative back pain on the basis of the history, much like an arthritic knee joint that we wouldn't hesitate to replace, or an arthritic hip joint that you wouldn't hesitate to replace. So I think this guy's pain is from that. The question again is 4-5 contributing? And yeah, I would go with a symptom-specific approach and try to identify whether 4-5 is contributing to it or not with a discogram, and potentially a block at 3-4 if that wasn't done, and then go ahead and address his symptoms with the appropriate consent, letting him know that this is where we think the problem is.
No, I mean, I think Paul brings up a really good point, because just like with vascular surgery, it's a progressive disease, and you treat what the problem is at the time. And, you know, if you're convinced that 3-4 is the problem right now, I mean, I don't think anybody would fault just treating the problem right now. Like Izzy said, saying, okay, well, you know, your disease is going to progress. You may need something in the future. You may not.
Well,
Just to,
you'd like to try to be as specific as possible, Scott. I don't disagree with what you said. I don't disagree with what Paul said, but I think that Izzy raised a good point too. I mean, he's got a really degenerative disc at that 3-4 level. Yeah, that probably is a thing, but now you have a tremendous lever arm on the next level down that's already degenerative. So
Yeah, I think that's the more
personally, I would
interesting
check
conversation
out
is not the diagnosis. Rick, I think that's exactly the more interesting conversation is what do you do to fix this, since you have a very long lever arm up above it. You've got previous hardware in place, and you know, what is your technique for getting this thing to fuse on the first try? I think that's the more interesting conversation, rather than the unknowable and nihilistic outlook of do we ever know where pain is coming from? So Rick, how would you tackle, or Izzy, this is your wheelhouse, old Scolies. How would you tackle this?
I wish you would have asked Rick that question, because I think his response would have been, I'd send it to Izzy.
And that's exactly what I would have said. So Paul, you did right. Good.
So this is I think you get a really easy interbody access to 3-4 with a direct lateral approach. And I would stage this. So I would do that first. I would see what his coronal alignment and sagittal alignment is after that. And then potentially I would do a perk screw just across that level. I think with navigation and robotics today, you could get away with just a screw and 3 and 4 and 2 rods on him, provided he's done well in between the stages. So that's how I think I would approach him.
Well, Paul, welcome to the TBI every Friday morning conference. Why in God's earth would you stage this? This is a one-level slam dunk. I agree, lateral is a great approach here. Perk screws, I agree. I don't get why you would stage it. What do you learn in 2 or 3 days in the hospital?
I like the concept of staging if you have questions about what their ultimate balance is, or what are you going to do additional levels, or if you have something that you're going to modify your plan. But I'm totally with you, Scott. This is just get in and out. We did a 1 hour OLIF. I always go anterior to psoas. I don't like going trans-psoas. And the only thing that I would argue with is I want to span. I've got free access to the rest of his lower lumbar spine and upper thoracic spine, so where I can get better fixation. There's a cost of being distal, but up above, you might as well get great fixation. You can get around the previous fixation fine because it's so medial, and you might as well make sure you're not going to fail at the top.
My only question is, and I just don't know enough about OLIFs. Do you burn a bridge for potentially an ALIF at 4.5 and 5.1, or is it a different plane?
Nope, not at all. I've done the retroperineum super forgiving, and I've done 2 3s on top of a 3-4 I did a year or 2 earlier, and it's like you were never there. And there's some scarring at the level itself, but the retroperineum reconstitutes itself, so not an issue at all. And actually tomorrow morning I'm doing a 4.5 OLIF for a non-union above an old 5.1 ALIF. It's not an issue.
Well, Paul, our access surgeon, at least the one that I use primarily, she will not do dissection before she has a kidney at the right space. And we've gotten in at 3.4, we've gotten, above 5.1. It doesn't make any difference. We tell the patient we might not be able to get in, but we've only had one case out of literally over 1,000 patients that we couldn't get back in at a level above.
Yeah.
But
no,
now
I've had to do revisions, non-unions or T-lifts, or a variety of reasons where, the access is a little harder if it's a non-union, because there's a little bit of inflammation. But I mean, I do my own access 2 to 5, 1 to 5, and it's not a big deal.
Hey guys, So one diagnostic statement and one therapeutic thing. Diagnostic. So this is a great case to start off these kind of case discussions with historic implants, because stainless steel is famous for harboring surprises in it. So I personally suggest always getting a set rate CRP on them, because they can have propionibacterium and they can have all sorts of biofilm material in there. Secondly, I have never regretted getting a CT myelo on those people, in this case, thoracic and lumbar spine, because the osseous detail paired with scar tissue, paired with neural elements, gives me a way better understanding. And I also get a TC99 bone scan. Again, same thing. SI arthropathies, I usually get a SPECT scan for the lumbar spine. Facet joint disease is truly just before. Now, here's my question, my pitch, and I'm going to get booed in a second. Here we have the heroes of disc replacement. And maybe I have to call Jack Ziegler urgently. But assuming that this is mainly a 3-4 disc disease, would there be any reason to be made to do a disc replacement with a nice semi-constrained implant at 3-4? This is a hard working doctor, and we want to return to work ASAP. And I have all the confidence in the world that between the fantastic people in this room, that you could do a very nice job of that. So I'm just going to hang up here. But I would,
again, you know, Terry Marnay talks about doing a lot, and he's a big proponent. I've done a few L5S1s. You know, the next, you know, the last degenerative level below a fusion, a long scoliosis fusion. Knock on wood. Now it's only a few cases, but I've talked to Terry about it, and he thinks it's not an unreasonable thing. You know, it looked pretty degenerative, but he may have tackled it.
Yeah, I think it's tough when with the lateral listhesis. I think you're asking a disc to do a lot that it's really not been studied and proven to do. I was drooling over 4.5 and 5.1 at some point, Jens, if they were to become symptomatic. But I mean, I agree with Paul. This is a fusion the whole way. But I do want to get Izzy's response, because we see the deformity guys in our practice and some other ones doing these kind of things stage. I want to know what the thought process is behind the stage thing. What do you learn between procedure A and procedure B that may change what you might do?
So I would have tried to preserve the 2-3 level. I'm not convinced that 2-3 level was fused originally, and I'd want to see the CT scan, the facet joints there, and allow that to still move, to be able to dissipate the forces. That's why I'd go with just a 1 level, with the option in between, getting him up, seeing what his sagittal coronal alignment is, and figuring out. Paul, this looks to me, this was an open case that you had done there. Yeah,
It was.
So I would have endeavored to work towards a PERC less invasive case with just a single level fusion. And that's the rationale to stage it for me.
What is he? I guess one of my main reasons for going posterior is I wanted as much autograft as I could get from him. I'm worried about this thing becoming solid, even with a titanium implant up front and infuse. I specifically harvested some of his own bone from around his Lukey wires and made sure I got a good open posterior and posterolateral fusion on him. So taking advantage of every bit of vascularized surface area I have. So that was really my main rationale. I agree. It's very amenable to PERC should you want to do that, but I want to throw the book at this guy to get him to fuse the first time.
Fair and reasonable. And that would have been a decision that I made in between stages, as opposed to all in one sitting. And it's just a subtlety of practice. That's all. There's nothing there that I would fault in any way, shape, or form.
So I wanted to ask
Hey, Paul.
So for sake of time, I think we're kind of approaching already 25 after, so we might want to move on to the next case, just so we can stay on time here. So Jason, do you want to go ahead and pull up your case?
Can everybody see my screen?
Yes.
Yes.
Okay. Good evening, everyone. My name is Jason Yee. I'm a spine fellow at Indiana Spine Group. Thank you for having me. I have no disclosures. Our patient is a 77-year-old female with rheumatoid arthritis who presents in 1999 with neck pain, bilateral arm pain, intermittent arm numbness. The symptoms were worse with neck motion, especially flexion. She feels unsteady on her feet and has failed non-operative treatment. On exam, she had an unstable wide-based gait. She was globally weak, bilateral upper and lower extremities. She was hyperreflexic, positive Hoffman, and upgoing Babinski. Available x-rays demonstrate clear C1, C2 instability. At baseline, her ADI was 5 millimeters, which increased to 11 millimeters with flexion. And PADI was 19 millimeters and decreased to 15 millimeters on flexion. She did also have a CT scan of her cervical spine, and that demonstrates a right-sided, medialized, and high-riding vertebral artery at C2. This is a slide from a paper published in 2014 in Spine by Lee et al. They endeavored to classify vertebral artery anomalies based on the degree of medialization and how high-riding it was. This particular patient was medialized and high-riding, which would be as class C2, and that accounts for about 18% of the population and is more common in rheumatoid arthritis. In summary, this is a 77-year-old female with atlantoaxial instability due to rheumatoid arthritis causing cord compression and myelopathy. She has a unilateral vertebral artery anomaly on the right. What would have been your treatment option in 1999 and your thought process, and how does that differ from your treatment options and thought process today?
Great case, very provocative. So this is Jens. I'll just take a first stab. So obviously we want to get a CT again. I didn't see that a CTA would be great, an MRI scan to check the pannus. The classic treatment would be to try to cable this patient, but in 1999, we actually had transarticular screws. And if you go back to the CT, there was a coronal CT, I think. Yeah, you can actually fire a pretty safe left-sided transarticular screw. Prior to that, I would probably have decorticated the facet joints and put in bone graft. I can't tell whether there's a big pannus in there or not. And I would have done a left-sided transarticular screw, and I would have, with a straight Mago technique, this is the theme of the evening, and I would have done probably a low-risk Sontag cable with a tricortical iliac crest graft. Thanks. Transoral decompressions were still done back then, and we had a superb ENT team at UW, but they've kind of fallen by the wayside. But back in 1999, we would have done the post-fixation, re-imaged the patient, and laid down the crick on the patient at a later date. Anterior procedure might be necessary. I must admit, I probably would have supplemented her with a halo if I had just a unilateral screw fixation. Back in 1999, we did not have the Goel C1 screws, and we would have avoided the cranium as much as possible because this patient does not have craniocervical disease yet. Thank you.
Thank you. Any other thoughts from panelists before we move on?
Interesting enough, from our chat box, Dr. Crockart in UK mentioned that he would do this transoral. Would anyone else kind of consider doing a transoral approach, and how would you back it up posteriorly?
So I debated Crockart numerous times over the years on this exact issue, and the problem that they had before Magrel's transarticular screws, the fixation they had was sublaminar wires, and passing a sublaminar wire before you took the odontoid out from the front is super dangerous. And so they would do their anterior transoral resection first, and then flip them over to stabilize them from the back. But the best way to destabilize the occipital-cervical junction is to take the odontoid out. By definition, you've resected the two strongest ligaments, the alar ligaments, the TAL, and you have an incredibly unstable occipital cervical segment when you go to roll them into the prone position. And then you have to do an occipital cervical fusion. And what they had then at that time was basically Ransford loops and sublaminar wires. But that was how they did it, because they had significant catastrophic neurologic problems with posterior instrumentation first. Once Magro came up with his transarticular screw, it changed everything. It absolutely changed how we take care of this problem. And as Jens said, you need to know, in 1999, we didn't have universal screw rod systems. Those came out in a year later, in the year 2000. The only disagreement I would say with Jens is that unilateral transarticular screws are extremely stable, very, very stable. And I routinely did not put them in halos. If I got a unilateral transarticular screw in, and as Jens said, then I would also do just a simple galley type or Sontag type wire construct. Jason can show you the.
Okay. All right. So the patient subsequently underwent a left-sided C1-C2 transarticular screw fixation with galley wiring and iliac crest autograft. The right side was not instrumented due to the reasons we discussed previously. At 3 weeks, this patient did well. Her arm pain and neck pain was improving, and she no longer had any symptoms when she moved her neck in terms of paresthesias that were produced by neck flexion. Her last follow-up at 9 months, she was continuing to do well. She was gaining strength in her arm and legs at that point, and she was feeling more stable on her feet. So this slide demonstrates some of the evolution of hardware that we've been through for C1-C2 fixation, from wiring to transarticular screws, clamps, gold plates, Harms construct, and C1 lateral mass laminar screw constructs. What are your thought processes on the evolution, what prompted the evolution, and the problems that we solved, the problems we created at each evolution, and what else we need to solve right now going forward?
What a great juxtaposition. And yeah, this is a beautifully done case. It shows also the difficulties of transarticular screws. You have to be so exacting, and you can see how this C1 part of that screw barely engaged the lower anterior lateral mass of C1. So this is an artful shot. It was a perfect AP. On the lateral, this angle must have been very, very hard. We had to start at around C7T1. I have a question for Rick there. Did you use cannulated screws ever, or did you just always do the Magro 2.5 drill?
Never. Magro hated cannulated screws for all sorts of reasons. Number one, they're ridiculously dangerous. And I've heard of people having to take wires out through a transarticular approach after trying to do a cannulated posterior C1-C2 construct. Also, you see a lot of times broken K wires because the drill does not ream parallel to the cable. Plus, you don't have as good of ability to place your drill exactly where you need for it to go compared to K wires. Will, once you start it, it goes where it's going to go. Whereas Magro taught a 2 millimeter drill bit, you can put it perfectly where you want it to go. And as Jens said, this shot, I will tell you, I still believe this is the most dangerous screw that spine surgeons have ever placed, transarticular C1-C2 screw. And as you see, it's difficult. The C1-C2 articulation had to be reduced. If C1 was not reduced, if it was anterior, the incidence of vertebral artery injury was extremely high because your shot was more shallow and not as steep. Plus, our hand many times had to be down in the thoracic spine, so you would percutaneously place. At that time, we didn't have really good instrumentation. I'd take a chest tube and cut it and do the drills, taps, and screws through a chest tube with my hand down in the thoracic spine. So this is very, very difficult to do, but an elegant technique, without a doubt.
So, Rick, was this is your case?
Yes.
One of the things that I think we should point out, or maybe you should point out, is what were the steps that you did to in terms of the surgery, the screwing and the wiring? Which did you do first and why?
Screw first. And actually the setup, I mean, those of us, I mean, Jens can say, I mean, the setup for this takes a long time. The C1, C2 articulation has to be perfectly reduced. You have to make sure that you can get your shot in older patients with a fixed cervical thoracic kyphosis. Many times you couldn't get the shot. So you ended up doing a wire construct and put them in a halo afterwards. So it took a lot to set these patients up before we even made your incision. But screw goes in first, and then because I couldn't get 2 screws in, I wired it, sort of a modified galley wire. And at that time, Jens was a little ahead of his time in putting bone graft into the joint. At this point, I was still putting the bone graft between the posterior elements of C1 and C2. But now, I mean, it's routinely the bone graft goes in the joint and not in the posterior elements.
So the one point that I was hoping you would come up or discuss was, if you wire this first, you're going to change the relationship between C1 and C2, and that's going to make your screw exceptionally difficult, if not impossible. So that was the thing. In these techniques, get that screw in first and then use the wire as your insurance or your supplemental fixation.
Right.
I have a question for Rick. When was the last time that you did a transarticular screw? Is this just totally anachronistic now, or are there certain reasons why you'd still do it?
Nope. A year after this, the year 2000, we had polyaxial universal screw rod constructs, and at that time, I told everybody, we will not do transarticular screws once we're able to place segmental fixation in C1, C2. And the reason is for what I just said, we can actually do that operation in subluxed segments that are not completely reducible, and actually use them as joysticks to obtain the reduction. And also, we don't have to worry about getting our hand in a bizarre position in the thoracic spine. So the last transarticular screw I did was in the year 2000. And it's the most dangerous screw we put in. I mean, I truly believe, I never had a vertebral artery injury, but boy, I thought about it all the time.
I've done some in younger patients with osteoarthritis who are higher end athletes, where I did not want a prominent piece of hardware in the back of the neck. And I've been very happy with that, because again, I did not just feel comfortable having their segmental screws, their harms, or the Goel harm screws right below the occiput. I'm not sure what others think about that. But so in younger patients, I have still done that. And I think the last one was exactly in the beginning of COVID. That was my last 16 or 18-year-old kid who was relatively small. But I don't think whether you think it's reckless.
Boy, I must really be behind the times, because I'm still doing 2 or 3 a year of these.
And why would you choose to do a transarticular screw over a segmental fixation, Izzy?
I don't like digging deep and mobilizing the C1 and C2 nerve roots as much. I'm using the robotics to get the screw across, and we're doing the pre-op planning, so I find it very efficient. I'm not reliant on the setup as much as you said with that. I've also had to revise cases, and one of the ones that I had to revise to transarticular screws was C1, C2 Mogrel screws, where the rod was placed so long it was digging into the occiput. So it was an issue. We just didn't have a way to revise. The screws were loose in C1 and C2. The only option was to get something across there, and the ring of C1 was also taken off as part of a decompression. So I had nothing in that case except transarticular screws.
Are you placing these with the Mazor or
Yep.
Globus or?
No, the Mazor robot. That's what I've been using. I've got a modified toolkit that I use, and it's actually a pelvic and fracture pelvic and acetabulum fracture reduction kit, which has got extra long drill bits and extra long guides that I use. And I get my trajectories using the pre-op planning and the robot. We clamp onto typically C5, 6, or 7, and it's still with them in the halo and the Mayfield tongs. They're stable enough that I don't worry about the spine snaking.
Oh boy, there's a lot of motion between C5 where your frame is and where you're, I mean, I'd feel much more comfortable if the frame was on C2.
Sometimes you can get it on there, sometimes you can't get it on there, and I agree, but we monitor it as best we can. And I use, if you know the Mazor system, I use the first generation clamps that we had, which are small, and I sort of kept them. Don't tell Medtronic that I have them. Someone may come steal them. But
you know what? They're listening.
That wonderful. They fit in the cervical spine really well, and it gives me the room to do what I need to do.
So Rick, are you using navigation?
No.
Why not?
Well, okay, I'll back up. So well, in the cervical spine, navigation isn't super accurate unless you actually have the reference frame on the segment, the vertebra that you're navigating. And for C2, I will tell you that my standard construct for C1, C2 now is lateral mass screws in C1 and laminar screws in C2. I do not use navigation for that. I don't use navigation to put lateral mass screws below C2 or occipital screws. I do use navigation for pedicle screws in C2 with the reference frame on the picture elements of C2. I just did that today for an OPLL with multi-level stenosis. And the reason I do that is my standard is when I place a freehand C2 pedicle screw, I get one lateral shot to make sure my trajectory is appropriate. Usually it's about 30 degrees angled cephalad, but sometimes it's different, and I get one lateral shot. And that's the most painful part of the operation for me, because I either have to put lead on or get behind a lead shield and I have to bring the C-arm in. If I use navigation, I just put the clamp on C2, I spin, and I never have to get an X-ray. I don't have to put lead on. And so I will navigate C2 pedicle screws. That's it. And if I was going to do a transarticular C1, C2 screw, I would do the same technique, because the danger of that screw is in C2, not in C1. The danger is the vertebral artery as it goes from medial to lateral underneath the IAP of C2, the C2. So that's really what you're navigating and what you need to stay away from.
Guys, I just wanted to say something about cable since I was in the chat room. So I'm going to flip my image around. I'm about to redo a failed C1, C2 cable fixation, believe it or not, in this era. One second, let me turn my camera around. Can't turn it around right now. I'm just going to turn it like this. Can you see it? So this is a non-union. It's pretty dramatic. C1, C2, this totally fell apart with cables in there. So this is what we're about to fix here. You see that?
When did they put the cables in, Jens?
These cables were put in, I think, a year ago.
Oh my God.
So this is, so this is happening here in the Pacific Northwest, and she has kinked vertebral artery. So I'm really happy about this. We actually just put TCDs on her. But to the questioner, C1, C2 wires are non-rigid. If you want to do that, you have to have a very quality interlaminar bone graft. And you probably, and this would be a question to our ISG colleagues, you probably should use that halo thing, because I just, they sublux, especially in unstable C1, they sublux the spine. Paul Anderson has shown that they tilt it backwards for fractures. It's unstable. This woman had a type 2 odontoid fracture, and it's just, she's now labored with this for 2 years. So I'll show this image one more time. You see the odontoid there?
Yep.
Yeah, so we're fishing these cables out and we're dissecting out the vertebral arteries. We have to probably, because she's so eroded here, we probably have to go into her occiput now. I don't think I can salvage that. But so cables, as it so happens, cables are, if you want to do cables, you have to probably say halo. So that's my thought.
It's a great case, Jens.
Hopefully it'll go well.
Rick?
Wish you well.
Rick, in the chat room, and somebody said, I think it was Jen said, that the reason why you don't use navigation, you have the Sassobot. We have a guy in our group too. We call him the Ted bot.
So just so we have enough time to get to the last case, I think we should probably go ahead and move on to Emily, our 4th year resident from IU, and she's going to be presenting another case.
Awesome. Great discussion so far. Thank you guys for letting me join tonight. Like I said, my name's Emily, and I am currently a 4th year resident and an aspiring spine fellow. So I also have no disclosures. Next patient is MS. She is a 15-year-old female who was originally presenting to a spine clinic in St. Gallen, Switzerland in 1991. She was presenting with 2 years of progressively worsening back and buttock pain and no radicular pain beyond her buttocks. She reported pain that was worse with ambulation, particularly with long distances, and she denied any bowel or bladder symptoms. And she had essentially failed non-operative treatment to this point. Her past medical history was non-contributory. On exam, she was noted to stand with the hips and knees flexed with a waddling gait when ambulating, tight hamstrings, and was otherwise neurologically intact distally. This is her pre-operative radiograph demonstrating Myerding grade 4, nearly 5 spondylolisthesis of L5 on S1 with almost 100% anterolisthesis. So given this is her, and I apologize that some of the imaging is incomplete just given the time when this patient waited and treated, but essentially her diagnosis is a high-grade isthmic spondylolisthesis L5S1 with intact neurologic status. So in keeping kind of with our theme, wanted to ask what some treatment options in 1991 and how y'all would have approached this case and what your thought process would have been.
Well, maybe I just want to ask, 1991, Rick, is that when you were in St. Gallen?
Yep. You're going to see a case that I was involved in St. Gallen. You're going to love it. You will love this case.
A question to Rick and Scott. When was Robert Gaines the visiting professor at TBI? Wasn't he there in 1989?
Yeah, you know what? I think he was there about that time, Jens. I'm not certain of the exact time. In fact, he did a case with us.
Yeah, I remember that. Yeah, I remember that. That's yeah.
Yeah, it was a great case.
Yeah, if you do the bilateral cliff approaches with the persuaders from behind, you're basically guaranteed bilateral foot drops.
Well, I will tell you that when Gaines came to do this case, it was I think John Regan's case. He came and did the vertebral body resection, and then I forget the fixation from behind. But in any case, the patient did well as with bilateral foot drops, but was very happy. So it was a miserable case.
So going back to that era.
Do you guys think that Izzy and Rick, do you think that with modern instrumentation that a Gaines procedure, I know it's been famously abandoned due to morbidity. Do you think it's a more viable option today with modern instrumentation and modern vascular surgery?
It's still a major ordeal. I don't know that it's more viable, but it's still a substantial effort. Yeah, you may have a better control of the reduction with today's instrumentation than we had in the early 90s. But it's still operating in tiger country.
It's a big case. It's not a microdisc, I understand, but I think with vascular surgeries, familiarity with L4 through S1 anteriorly and our modern instrumentation, is it something that is the dustbin of history forever, or is it something that, and I'm not I know the answer. I've already seen this case long ago, so I know where we're heading with this one, but it's just a sort of theoretical question more than anything else.
I would keep it as listed as it's a tool, it's an option that has to be considered carefully with the right hands to do it.
Yeah, I think with the modern internal fixation, we can get the reduction, at least maybe not complete reduction, without doing the resection, Paul. I think that, we're a lot better at dealing with these anteriorly. And there's different techniques that you can try to reduce these high-grade ones without doing a resection.
Awesome. So I had kind of jotted down some other just considerations, like y'all were saying, anterior versus posterior, what type of bone graft you might be utilizing back in 1991, and then uninstrumented versus instrumented arthrodecies and some of the different instrumentation that was available at the time. So ultimately, this patient underwent.
One other thing, I'll just make a comment here. In that era, particularly in France with Jean Dubosset, who I was visiting during that same span of time, these young girls, young patients, would have been put in traction for weeks and weeks in bed over a bolster and get a slow reduction of that. So that's one of the things, and that I think has become a lost art, the use of traction for a spondylolisthesis of this magnitude.
My question is that one of the things that we were doing back then for high-grade spondies, and I don't know, is this too high grade to do the, I think it's the Bowman procedure where you do, back then it was like a fibula at the L4-5 disc across the 5-1, and I've done it with custom BA. Well,
he did it
what's
from
the one?
sacrum into five.
What's the procedure from the front where you
Kellogg
expose
speed.
4-5? Huh?
Speed, Kellogg speed.
Yeah, and we
Kellogg
used
that. Address the 4-5 disc and put a fibular strut across the high grade.
We did it with custom BAK cages at one point. They made BAK cages to do that. But is this too high grade for that? I don't know.
No, it absolutely, the higher grade, the easier it is, actually.
Okay.
All right, Rick, what did you do back then?
Okay, so ultimately this patient underwent a series of reductions using an external fixator that was placed in the operating room with Chance pins in L4 and S1. She underwent a reduction every 6 to 8 hours where a maneuver was performed to progressively reduce the spondylolisthesis in the fluoroscopic suite until she developed neurologic symptoms in the form of EHL weakness and dorsal foot paresthesias. The reduction maneuver would then be reversed until her symptoms were resolved, and this process was repeated over 5 days until no further reduction could be achieved without the onset of symptoms. And then she ultimately returned to the OR for definitive stabilization with both anterior and posterior fixation. And this is just an image I found from a Karampolis article that was published in 2011 or 2012, kind of demonstrating, I think, roughly what this external fixator construct would have looked like clinically. This is and Dr. Sasso, please correct me if I'm wrong. This is the only image I was able to find. But and then this is an intraoperative fluoro shot from when the Chance pins were originally placed in the L4 and S1 vertebral bodies. And then the last image on the right is her ultimate reduction. And unfortunately, we didn't have an image of the definitive anterior and posterior fixation, but I believe she had an interbody fusion and then some posterior fixation with screws.
Yeah, so that's as good a reduction as we could get all the way on the right, without her screaming in pain on the top of her foot and EHL weakness. What I learned is that when you reduce a high grade slip, I don't care how long it takes you in an operating room, you are stretching the L5 nerves, and it took almost a week, 5 days to get it this reduced, and we couldn't reduce it anymore. And so that's why I am not a reduction zealot for these high grade slips, because the incidence of L5 radiculopathy is so high, just as you guys just reported in your experience with reductions. But this is how Magral did it with his external fixator, and you know, we had to cut a hole in the bed in order for her to lie down in bed with this big thing sticking out of her back for a week.
So one of the things that we point out that there's the L5 palsies, but really, why is the L5? Is it truly being stretched, or is it being compressed by the iliolumbar ligament that's sitting there, coming off the dip of the transverse process of L5 as you're pulling it back, impinging on that nerve? Because that's one of the things that, and I think it was Bob Gaines said, well, you've got to make sure you release all those ligaments all the way around to get it back. So that's a question that I've always had. I just didn't understand why the L5 is actually being stretched, or is it just being compressed because we're pulling it over the sacral dome, or being compressed by the iliolumbar ligament as we're pulling things back?
Great
It's a good question, Izzy. I mean, we don't know.
I don't
You-
know.
you
Wouldn't
know-
it be, I'm sorry.
But Rick, I don't know if you knew Charlie Edwards, but he had a technique where it took him
Took him
forever
all
in the
day.
OR.
Yeah,
Yeah.
he'd go drink coffee and have lunch, and he'd come back and do a little bit. But again, here
And
it took
all
me
day
5
long in the OR, all day long.
Yeah, I know.
Wouldn't it be interesting though, as a young person that had the surgery, to get 31-year follow-up and find out how functionally they are now and what their x-ray looks like now?
Okay, that's for your next fellow, Rick.
Go
Yeah.
to Switzerland,
Yeah.
track her down, find her.
You go to St. Gallen and hunt down this patient.
Yeah.
The only post-operative information that I do have is that she had a relatively uneventful post-operative course and was discharged without any neurologic symptoms.
All 5
and-
nerves were working. They were
Yeah,
working.
but that's because she was in so much pain with your treatment. She would never, ever, ever come back.
Good.
And then I just included, similar to Dr. Yee's presentation, some images of kind of what y'all had been describing with in the top left, some spinous process traction wires and pelvic X-fix that was originally described, I believe, in 1982 as a reduction technique, followed by this using Harrington rods and hooks when those were developed in a Zielk sacral bar in the middle. And then obviously the other instrumentation that we described as well. So just interesting to see the transition. I mean, as far as now, as how often are you all, I know Dr. Sasso, you just said you're not a reduction zealot, but what do you all have standard like goals as far as reducing these, or you just kind of get what you can take? And then as far as fixing them, are you typically doing an anterior and a posterior construct, or just posterior only?
So I would say that it's a partial reduction. And the most important part of the reduction is actually the sagittal alignment. And most of the time that reduces with positioning them on the operating table. A lot of times the translation will reduce. The first 50% really is not so bad on the L5 nerve. It's the last 50% that is horrible on the nerve. That X-ray down in the right lower corner, that's the Kellogg speed operation through the disc space at 4-5, and the strut is placed across, and then an interbody graft is placed at 4-5 to cover the entry hole. But I reported, probably the largest 20-some patients with high-grade slips treated with fibular strut grafts without any L5 nerve root deficits. I know a lot of people it just is intuitive. We want to pull L5 back, but what I learned so much in Switzerland is that's a really bad thing. We can make the x-rays look great, but we knock out their L5 nerves in a young athlete, especially. That's the worst thing you can do for them. And all we really need to do is get a solid fusion. That's all we need to do. We need to get it to solidly fuse. And to do that, you need anterior and posterior fixation.
So the one thing, Rick, that I think we appreciate today far more than we did 30 years ago was global sagittal alignment in these cases. So you've got to really assess where their head is in the sagittal plane, and then decide what type of correction you need at L5S1 without disrupting them or keeping them balanced in that sagittal plane.
Rick, I saw a question on the chat. Was intraoperative monitoring done in 1991 in St. Gallen? I'm guessing the answer is no, but where we did our fellowship, they were doing intraoperative neuromonitoring pretty sophisticated back in the late 80s, early 90s.
Didn't have it in Switzerland when I was there.
Yeah.
Well, guys, it's right on the nose at 9 o'clock, and it's kind of fitting that we're ending this because it looks like the Rothman Institute is presenting high-grade isthmic spondylolisthesis next week. So this should be a nice segue for you guys next week. So just want to thank everyone for chiming in today. This is really kind of what we hope for it to be as far as kind of a nice conversation. So thank you, everyone, for participating.
Hey, it was a great talk and it was a great format. Thanks, guys and
Good
gals.
job.
Night.
Thank you.
Thank you.
Thanks, everyone.
Outstanding. Outstanding program. Thank you.
Jens,
And-
the only disappointment, you didn't show us intraoperative films.
No, I'm too slow. What can I say? Next week. Okay.